There are some calls, some patients that we feel very, very comfortable taking care of. Why is that? Well, it's because we take care of them every single day. These are the things like chest pain, like STEMIs, like strokes, like cardiac arrest, like respiratory failure. We deal with them every day. It's our bread and butter. And then there are some types of calls, some types of patients that perhaps we don't see every day, perhaps we don't feel as comfortable with. And these are the types of patients, types of calls that it is very helpful to see practice consensus guidelines, things that tell us this is what best practice is to manage these types of conditions. Well, one of those areas where I don't see patients every day, I suspect you are the same way, is pregnant patients with hypertension, pregnant patients with seizures, or recently pregnant patients with postpartum hemorrhage. ACOG, the American College of Obstetrics and Gynecology, has just released some EMS guidelines. These are guidelines that are based on time-critical interventions for a very sick group of patients. ACOG reached out to me and said, we would love your help getting the word out to the EMS community about these guidelines. And I jumped at the opportunity. I jumped at the opportunity because ACOG, turns out, was very helpful to me when I was in medical school. They were one of the go-to sources for really good information for me in medical school as I was learning practice. And throughout my practice, they have been a go-to place for me to go and identify what best practices are in this population of patients that I don't see very often. So for this episode, we have two experts who are going to come and talk to us about these guidelines. Stick around and we'll be right back.
What is a lighthouse? It is a tower with a bright light at the top, located at an important or dangerous place. The main purpose of a lighthouse is to serve as a navigational aid and to warn of dangerous areas. Welcome to the EMS Lighthouse Project podcast, illuminating the darkness of current EMS clinical practice with the bright light of science. Here's your host, Dr. Jeff Jarvis.
Howdy, y'all. I'm Dr. Jeff Jarvis. Welcome back to another episode of the EMS Lighthouse Project podcast, where we shine the bright light of science on the darkness of clinical practice. Well, we have some great ACOG content for you here. We want to talk about these new guidelines, and to do that, we have two great guests, Dr. White and Dr. Zahn. Dr. White, would you introduce yourself, please?
Sure. My name's Jenna White. I'm an emergency and EMS physician in New Mexico. I'm also the chair of NAMSP's Rural EMS Committee. And I've been working with ACOG on a project over the last few years looking at improving the recognition and treatment of obstetric emergencies in non-obstetric settings.
Outstanding. And you do a great job on the Rural Committee. Thank you so much for that. We get to work together with NAMSP on that committee. Awesome. Dr. Zahn.
Thank you, Jeff. Hi, everyone. I'm Chris Zahn, the Chief of Clinical Practice, Health Equity, and Quality at ACOG, and I have the honor of working with Jenna and the team developing these resources. They started several years ago, but have really made an important impact in the non-obstetric setting. Thank you for the opportunity to be on.
Yeah, thank you for being here, both of y'all. Chris, you mentioned these started several years ago. Since you are obviously involved with pushing these out to the different communities, can you give us a little idea about why ACOG felt the need to create EMS guidelines and then the process that you went through to create those guidelines?
Sure, Jeff. And again, thank you for the opportunity. So this did start a number of years ago. And actually what really triggered this was a phone call received from one of our former ACOG presidents who said there was yet another maternal death due to hypertension that wasn't recognized when the patient presented. She was told she was tired. She just needed to get some rest to go home. She had a stroke and passed. And we said, we have got to do something about this. And working with the CDC, we also knew that there was some data on patients presenting with obstetric emergencies in non-obstetric settings, such as EDs, in the first responder setting, urgent care clinics, et cetera. So we embarked on this. The first stage of this was to get together with about 20 other organizations involved in ED, EMS, and urgent care to really try to identify what the major issues were and where the gaps were as far as guidance and education. And we did that, and we developed the resources to identify a couple of the main problems: hypertension, eclampsia, hemorrhage, and cardiovascular disease in pregnant and postpartum patients. After that, we looked to our content to help translate what we had in guidance related to these to a format that was most useful to those audiences, recognizing that EDs might use different resources than what EMT and EMS might use, as well as urgent care. Jenna was instrumental in being part of the team and leading the team to help us develop those resources, went through countless, it seems like, rounds of review and testing to eventually produce those. But it resulted in algorithms for the EDs, the checklist format primarily for EMS and EMT, as well as urgent care. And we slightly tweaked the topics for each of those audiences depending on what they were most interested in. But again, they underwent countless rounds of review to make sure that these were useful in a format, as well as the content that was most useful for these groups.
Did you release the ones for the emergency department and EMS at the same time?
No, we actually started with the ED resources. So those came out probably about 6-8 months or so before the resources for EMS and urgent care. And just really want to do a shout out to the NAEMT and NAEMSP. It was just such an important collaboration to make sure we got it right. And again, thank you to everyone involved in this project.
Well, I love hearing that. The reason I was asking is I remember seeing these first hit my radar in the emergency department, and I was just trying to make sure that I wasn't missing the EMS version. It actually was a little bit after, so that makes me feel a little bit better. Let's talk about hypertension. Can you talk a little bit about the pathophysiology of hypertension in pregnancy? And the main reason I'm asking this is I've been a paramedic for a while. I was a paramedic for 10, 11 years before going to medical school. And back in the day, we used to give nifedipine for all patients with hypertension because we were worried, not to put too fine a point on it, but that their heads were going to explode. And what we found out was that very rarely did their heads explode. And way more commonly, we actually induced ischemic stroke because we pulled the rug out from under their blood pressure, if you will. They had been chronically hypertensive, built this dependence on hypertension up for a long time, and then we yanked it out from under them. And now we finally got through to everybody that, hey, let's not aggressively treat hypertension in the non-pregnant population, and along comes this recommendation to aggressively treat it in the pregnant population. And that really begs the question, what's the difference? So can you, as it turns out, I've been educated on this, there is a difference. Can you talk to us about that physiology?
Sure, would be happy to, Jeff. So there are some physiologic changes that kind of overlap both considerations for hemorrhage as well as hypertension that I think are sort of important foundational points. So first of all, maternal cardiac output increases about 40 to 50% as a woman approaches term. And at the same time, systemic vascular resistance declines, which actually means for blood pressure, there's a relative hypotension, so to speak, particularly in the second trimester, that normal blood pressures are about 5 to 10% lower, but then they start to approach baseline normals again as a woman nears term. Pregnancy is also a hypercoagulable state, and that'll be a little bit more relevant when we talk about the risk of stroke, but that increased cardiac output, although the potential for the stability of the blood pressure is important when it comes to cerebrovascular physiologic changes. So in normal pregnancy, again, with the maternal output increasing, there are some effects on cerebral blood flow as well as cerebral perfusion pressure. And it's poorly understood, but there is the autoregulation and adaptation in the cerebral blood flow that even though the maternal cardiac output increases and there are minor changes in systemic blood pressures, the cerebral blood flow is maintained fairly constant. Because of autoregulation and some of the changes that occur in that cerebral mechanism. However, in preeclampsia, some of those features are lost. So first of all, the vascular changes, medial hypertrophy in particular, that can occur in normal pregnancy does not happen in preeclampsia and eclamptic patients, which makes these patients more susceptible. And they do therefore lose some of the autoregulation that would occur normally. With that loss of cerebral blood flow autoregulation, there is a chance and the potential for hyperperfusion. And because of the endothelial dysfunction that occurs, there's an increase in the blood-brain barrier permeability, which leads to edema. And actually, in the studies that have looked at the physiologic and anatomic and imaging changes in eclamptic and severely preeclamptic patients, it actually very much mimics a hypertensive encephalopathy. And in fact, features of posterior reversible encephalopathy syndrome are seen in these patients as well. And it's, again, that combination of the loss of autoregulation, hyperperfusion, and edema that sets these patients up for central or cerebrovascular compromise. Related to stroke, and this is, I think, a really important point, these changes, these hypertensive encephalopathic changes, are actually seen at lower blood pressures in pregnancy and in the postpartum period, therefore leading to the potential for stroke at lower blood pressures compared to what you see in the non-pregnant, non-postpartum population that you mentioned just before we started this. We also know that probably because of these same encephalopathic features, that patients that have neurologic symptoms, such as scotomata or the classic severe headache, the worst that they've ever had, that can be seen, it can actually be sort of the preemptive sign or symptom before patients actually develop a seizure. And again, this is seen at lower blood pressures than we see in the non-pregnant and non-postpartum population. The other thing, too, as mentioned, pregnancy is a hypercoagulable state. So not only do you have these cerebral vascular changes, you're also putting that in the setting of hypercoagulation and the fact that preeclampsia is an inflammatory condition, which further affects the cerebral vascular response with spasm and thrombosis. So that combination even sets patients up at higher risk physiologically for stroke. Again, and it can't overemphasize the importance that risk occurs at lower blood pressures than you would see in the non-pregnant, non-postpartum population. We could probably talk this entire episode about physiology, but I'll stop there.
We probably should, because I find it fascinating, and I think Jen and I might have our EM cards pulled if word got out that we actually thought physiology was pretty cool. So I appreciate that. I love it. Well, so hypertension definitely has different consequences in the pregnant patient, that, at least timescale wise, than in the non-pregnant patient. Well, let's talk a little about what we should do about that. And with that, let's jump into the guidelines. Jenna, do you want to talk to us about these guidelines? And I think maybe a good start is, since Chris was talking about this risk happens at a lower level, perhaps it's good for us to actually define terms here.
Yeah, absolutely. Let's do it. So this color-coded chart that we see here is actually, it appears exactly as it does here in the guidelines. And we designed the chart this way with sort of the color coding and the increasing number of exclamation points in the left margin there to really just draw folks' attention to the fact that, again, we are asking people to, asking EMS clinicians to be aware of the possibility of really serious pathology occurring at much lower blood pressures than might draw our alarm in a patient who is not pregnant. Chris and I have this running joke between us that as an emergency physician, if someone's blood pressure in the emergency department or in a non-pregnant patient in the pre-hospital setting has 3 numbers in their systolic pressure, and the first number is not a 2, I probably don't care because we see such a range of elevated blood pressures for so many different reasons in patients who are receiving emergency care. They're frightened, they're scared, they're in pain, perhaps they've missed some doses of their home antihypertensives. And so we really, as emergency folks, get desensitized to seeing pretty high blood pressures, frankly. And we need to, when dealing with pregnant and early postpartum patients, really detrain ourselves from that pattern. And so we designed this chart to help folks be better able to do that. So looking at those systolic blood pressures greater than 140 is kind of our threshold for initial concern. And if you have a patient that falls into the yellow range, as depicted here, with systolic pressures between 140 and 159, or a diastolic number between 90 and 109 millimeters of mercury, we want people to recognize that these blood pressures are potentially abnormal, and that patient could go on to ultimately receive a diagnosis of preeclampsia or another hypertensive disorder of pregnancy. And so this is kind of like our first level of like caution, be aware, start measuring these blood pressures regularly, and let's get this patient to some heightened levels of care so that they can receive some additional workup. Moving on to the orange bar here, these are patients who have that same range of blood pressures, but who also have some worrisome symptoms like severe headache, blurred vision, right upper quadrant, or epigastric abdominal pain. These are patients who essentially, with these criteria alone, blood pressure criteria and symptoms, they have met the diagnostic criteria of preeclampsia with severe features. And these are patients that are going to require treatment with magnesium sulfate and transport to an obstetrically capable facility. And then lastly, we have kind of the most severe or patient category that would make us the most concerned. And those are patients who have blood pressures that exceed 160 systolic or 110 diastolic. These are severe range blood pressures, and these patients also should receive magnesium. But in addition to that, also really need to have their blood pressure controlled with antihypertensive medication. So that's sort of the threshold for blood pressure treatment, is that 160 systolic or 110 diastolic number.
And that's regardless of symptoms, correct?
Correct.
I like it. Well, when we're talking about treatment, so it looks like the first step here is just awareness when your pressures are getting into the worrisome range. And then once they're in that orange range, if you meet those criteria and have these symptoms, then treat, but treat with MAG. And then in the red zone where the pressures are high, regardless of the symptoms, treat with MAG and the antihypertensive. Is that right?
Exactly.
Perfect. Let's talk about MAG, shall we? Since that's first up.
So I think a really key point to understand about the administration of magnesium in hypertensive disorders of pregnancy is that magnesium sulfate is not in and of itself an antihypertensive. The reason that we're giving magnesium is to prevent the patient from developing seizures or potentially other neurologic complications of their hypertensive disorder of pregnancy. And that's something that I think really, I don't think I completely understood well until I actually started doing this work with Chris and the rest of the folks at ACOG, is that really the point of magnesium is to prevent seizures and not necessarily to control the blood pressure. You may see a little bit of a decrease in blood pressure when magnesium is given because it does have smooth muscle relaxant properties, but that is not the primary aim of magnesium. The primary aim is actually to prevent neurologic consequences, particularly seizure, in patients who are pregnant or early postpartum and have elevated blood pressures. And magnesium is very effective to this end. In patients who are pregnant or early postpartum and have hypertension, the adjusted odds ratio for the prevention of seizure is 0.41. So 59% lower odds of having a seizure if patients are treated with magnesium versus if they are not. So critically important medication to prevent patients who have hypertensive disorders of pregnancy from seizing.
I like it. So clear the reason, just want to make sure that I got this right. The whole reason we're giving the MAG is for seizure prevention. Any other benefit is just a bonus. So if it might lower the blood pressure a little, bonus. So we see that there is another significant variable. We have some images up here from a Cochrane review, systematic review and meta-analysis that talks about a benefit of placental abruption, decreased risk. Turns out that's just icing on the cake. That's not really the reason we're giving the MAG. Is that right?
Right, exactly. Yep.
Perfect. You know, I love talking about the number needed to treat because it's a concept that really helps me gauge how important, how much benefit we get from a treatment. Can you talk about the number needed to treat for seizure prevention with MAG?
Absolutely. So for those patients who have elevated blood pressures and also some degree of severe features, whether that be those numeric criteria alone or kind of the intermediate numeric criteria, but those concerning physiologic features, their number needed to treat with magnesium to prevent a seizure is actually only 36 patients, which I think is pretty remarkable when we think about the fact that we have many other types of interventions that we might treat patients with in other conditions that actually have far less favorable number needed to treat ratios. Jeff, how would you say that number needed to treat? Is that just like, it's its own thing?
NNTs. Yeah. Yeah. It's, oh God, now you're going to put me on the spot and make me remember the formula. I think it's one minus the absolute risk. Oh my God. I'm going to have to go look this up. Yeah, I definitely should have stopped and looked this up. It's 1 divided by the absolute risk reduction. Absolute risk reduction is the difference between the control risk and the intervention risk. 1 divided by absolute risk reduction. The idea here is how many patients do you need to treat to get one benefit? And just to help put 36 is pretty good. If you look at statins for primary prevention of coronary vascular disease, it's in the hundreds. If you look at something we do every day, which is give aspirin to patients with STEMIs, that number is 42. So a lower number is good. More patients benefit, more patients with hypertension and pregnancy benefit by not having a seizure with MAG than benefit from avoiding death in a STEMI. So that's fairly impressive. Well, if we're going to give MAG, how should we give it?
So to administer magnesium, we're going to administer an initial bolus, and that's 4 grams IV over about 20 minutes. And then we're going to follow that with an infusion of 2 grams of magnesium sulfate per hour. I will say that the administration of the magnesium bolus can be unpleasant for some patients. And so if you're going to be giving the 4-gram magnesium bolus, I would recommend just advising your patient that they may experience some flushing, some sense of like warmth or heat kind of washing over them. It can sometimes be a little bit panic inducing for patients. So just kind of let them know that this is really important for their treatment. They're going to feel kind of weird. It will get better when the infusion finishes, but that's a little bit of nice anticipatory guidance to provide your patient that you're giving this big slug of magnesium to. If you have a patient for whom you cannot obtain IV access, these patients many times can be very edematous due to third spacing, and so it can be tough to get an IV. And so you can actually give the magnesium dose IM, and that would be 10 grams of magnesium split 5 grams in each buttock, given intramuscularly. And that's an alternative way to load patients with magnesium.
Also, ouch.
Indeed.
Well, let's talk. So that's MAG. Let's talk about, and we're, again, as you pointed out, we're doing the MAG not to treat the blood pressure, but to prevent seizures. Speaking of that, let's talk about this because you're an EMS medical director also. we see seizures, it's not a terribly uncommon thing for us to see patients with seizures. It's a more rare thing to see patients who are seizing because most seizures stop. Well, actually, all seizures stop. Most stop fairly quickly, let's say. There is always this question around this population. I have a patient who's seizing. What do I give first, the MAG or the benzos? And as I've been able to determine, the literature on this never answers the question we want it to, like most literature, which means this is a prime thing for people to yell and scream and turn into a culture war about. The things with the least evidence are the ones that get people into a tizzy. And I don't mean to say there's not evidence for seizure prevention. There clearly is. I mean, which one you give first. So when you talk to your clinicians in your EMS services, how do you talk to them about which medication you give first for the patient who's seizing in front of you?
So I think if it is clear that this patient is having an eclamptic seizure, i.e., they have a gravid abdomen, maybe they've been in your care for a while and they've had some high blood pressures and have kind of met they have kind of a very classic presentation for the development of eclampsia. I think in that patient, it would be reasonable and wise to give them magnesium first, especially if you already have an IV established on that individual. However, that is probably not going to be the reality for most of the patients that we encounter with an eclamptic seizure in the pre-hospital setting. It may very well take some time to actually determine that this patient is indeed pregnant or within 6 weeks postpartum. There may not be a reliable historian at the scene to give you all the information you need to know to actually determine that this is an eclamptic seizure. And so in writing these guidelines, we acknowledge that it is possible, if not likely, that many patients are going to get a dose of benzodiazepines initially to manage an ongoing seizure. And that is completely fine. I would just emphasize that as soon as you determine or suspect that this is an eclamptic seizure, that you administer magnesium as soon as you feasibly can.
I like it because what we're trying to do here is make sure they don't have subsequent seizures. Great.
Exactly.
Well, so now we have decided that we're going to treat the blood pressure because it met these goals. Let's talk a little bit about how we're going to do it and what we're looking for here. So one of the things that got me was this emphasis on timely treatment, which puts this squarely in the realm of EMS, which is why ACOG has reached out to the EMS community. I think a lot of our colleagues will say, well, why is this an EMS issue? Turns out there's a reason for it. So can you talk to us about what the goals of treatment with antihypertensives are?
Yeah, absolutely. So in the ACOG practice bulletin for this topic, we described that the goal for administration of antihypertensives is within 30 to 60 minutes. And many folks will have EMS transport times that are significantly shorter than that. So I think it's a really great question to pose in this community is like, well, if we have 30 to 60 minutes to do it, like, why is this something that EMS clinicians need to be doing primarily, especially if we have really short transport times? Well, to answer that question, I do just want to point out that we have good literature, particularly with regards to looking at EMS administration of pain medications and how long it takes when EMS is delivering a patient to a hospital for them to get pain medications, right? Because the patient has to be registered, someone has to get their allergies and their medication list, and then someone has to go to the Pyxis and make sure that they can access, the medication in the Pyxis. And there's actually quite a bit of delay between arrival at the hospital and administration of pain medications to patients that are in pain. The same exact thing happens when we're talking about getting critical medications on board for patients with a hypertensive disorder of pregnancy. So I think even if you have a short transport time to the hospital, you will definitely see a delay in the time between your arrival to the hospital and the patient receiving those medications. Not to mention the fact, I'm a rural EMS medical director, so we have very long transport times to the hospital, sometimes in excess of 2 hours. And so for folks who are practicing in more rural areas, I think this only makes sense that we be administering these medications in the field, because there's simply no way that we're going to make that 30 to 60 minute time to goal time for treatment when we're talking about the long transport times that many of our rural EMS clinicians are faced with every single day. If we're treating blood pressure, we want to treat to a target of a systolic of less than 150 or a diastolic blood pressure of less than 100. So again, we're not trying to drop these patients to extremely low blood pressures, really just trying to aim for a moderate decrease outside of that severe range. And we'll be very happy with that. And I think important to note, to just underscore the point of like, well, why is it important to treat this? Like, we're just treating numbers. And in fact, we actually have some really good data that suggests if we don't treat these patients in a timely fashion, we actually have some really good evidence that suggests that they're at significantly heightened risk of experiencing some element of severe maternal morbidity, whether that be the development of acute renal failure, the development of congestive heart failure with pulmonary edema, the development of a stroke. So the article that you have cited here on this slide, Jeff, the Gupta and Green article, actually demonstrated that for patients who were treated in a timely fashion, so within that 30 to 60 minute goal time to receive antihypertensive therapy, those patients actually had 72% lower odds of developing some feature of severe maternal morbidity. So I think this paper really clearly puts an exclamation point on the need for patients to receive treatment in a timely manner, and therefore puts this squarely in the EMS realm.
Absolutely. And this paper, thank you for sending me this paper, by the way. I really wanted to know, because that's the kind of nerd I am, I really wanted to know what the evidence behind this this drive to early treatment was. And as I was looking at different papers, this is all, nobody is going to randomize women into early versus delayed care. That's just, it's not ethical. So that puts this squarely in the realm of epidemiology studies. And this is just a classic epi study. So if anyone is looking for an example of a classic epi study, boy, I'd recommend the Gupta one. It answers exactly the question we're looking at and has some really good methods. Well, so these are the treatment goals. Let's talk about how we get the blood pressure down below 150, what some of the options are.
Yeah, absolutely. So in creating this guideline, we really wanted to provide several options for antihypertensive medications that could be utilized to treat elevated blood pressures in this patient population, acknowledging that there is a wide variety of scopes of practice across the country. There are of medications that are going to fall outside of what is feasible for, say, a small rural EMS agency to carry. And so we wanted to give a few options for effective ways to treat elevated blood pressures in these patients. And so the three medications that are in the guideline are labetalol, nifedipine, and hydralazine. Labetalol and hydralazine are going to be given IV, and nifedipine in its immediate release form is actually an oral medication. So that makes it really accessible for those EMS clinicians who maybe don't have IV access on a patient, or for those more kind of elemental levels of licensure for whom the initiation of an IV is not in their scope of practice. You may choose to carry one of these over the other based upon classes of medication you already carry, based upon whether or not you have an alternative use outside of this one for any of these medications, based upon cost. And so we really wanted to make sure that there were a number of good options for EMS clinicians and the decision makers for EMS systems to have to determine a good option for treatment for these patients.
I love it. So labetalol, nifedipine, the return of our old friend, nifedipine, and hydralazine. So great options here. So I think that gives us a pretty good idea about the guideline on treatment of hypertension and treatment of seizures and seizure cessation. That is one of the guidelines, or two of the guidelines, depending on how you look at it. The next guideline is about hemorrhage. So why don't we go back to Chris? And Chris, can you talk to us a little about the postpartum hemorrhage guideline? Why don't you start off just by telling us what postpartum hemorrhage is and isn't, and then what we can do about it?
All right. Thank you again, Jeff. So actually, before we get to the definition, based on your love of physiology, I have to throw a little bit more in there. And we talked a little bit about that related to the hypertension guideline. But as mentioned, cardiac output significantly increases in normal pregnancy. The blood volume also expands by about 40 to 50%, although the RBC volume doesn't expand by quite as much. So normally there is a physiologic anemia in pregnancy. And again, the previously mentioned slight decline in blood pressure, particularly in the second trimester, that recovers to normal. The reason those physiologic changes are so important, it's evolutionarily beneficial, but at the same time a problem. So it actually protects against hemorrhage because there is such a significant expansion in blood volume. The physiologic anemia could be a little bit problematic when it comes to hemorrhage, but nonetheless, pregnant women significantly expand their blood volume to accommodate some degree of bleeding at the time of delivery. The problem is patients can lose a lot of blood before they will show signs and symptoms. So the typical hypotension tachycardia that we look for may not show up until patients lose about 1,500 cc's. So that physiologic adaptation actually masks signs and symptoms of significant hemorrhage, which is problematic in the recognition stage. But hemorrhage is defined as greater than 1,000 cc's. And again, the delay in presentation may be problematic. So assessment as best as possible of blood loss to try to anticipate that is really critically important, especially if considering interventions like transfusion. The typical options that we do for hemorrhage are uterine massage to help stimulate the uterus to contract. Oxytocin is routinely given in the obstetric setting. There's a lot of discussion about, do you do it after the infant delivers? Do you wait until the placenta delivers? And actually, it doesn't make a difference in postpartum hemorrhage. The key thing is to get it on board. And it's also important to recognize that oxytocin is often used for abnormal labor to try to improve contractions, but that is an infusion that is a very different rate than basically running something wide open after delivery. So that is not an approach to use if there is still a fetus inside. Typically, again, oxytocin is the first line therapy. Then there are other options if the hemorrhage is still occurring. Misoprostol is listed as one. Methergin is another. TXA can also be used. And again, these are typically second line agents. I think it's also important to recognize that we're focusing on uterine atony. Hemorrhage can also occur due to retained placenta, possible laceration, or an underlying coagulopathy, but in most cases, 70 to 80% of the time, postpartum hemorrhage is due to uterine atony, and therefore our goal is to try to get that uterus to contract to prevent the blood flow. I think another really important physiologic feature, and this actually will tie into the hypertension as well, is a uterine blood flow is strictly related to maternal blood pressure flow. There is no autoregulation that governs flow to the uterus. And if you think about it, it evolutionarily makes sense. We don't want a patient who just ate Thanksgiving dinner to divert all her blood flow to her intestines and none to the uterus. So it's strictly, again, based on maternal flow without that ability to auto-regulate. So as a result, because of that increased cardiac output, if the uterus doesn't contract and therefore cramp down around those vessels, it is a wide open pipe. So really important to get the uterus to contract to try to control that blood flow. Also want to tie that, just if I can, back to the hypertension. And Jenna mentioned about not lowering the blood pressure too much. You basically just need to get those patients out of that severe range. Because if you lower it too much, you're going to negatively impact the uteroplacental flow and therefore cause some compromise to the fetus. So again, it's getting it below severe, but not back to normal, so to speak.
Very good. Let's talk a little bit more about oxytocin, misoprostol, and TXA here. When you're giving the oxytocin, it looks like there are two ways to do it. There's the traditional way, which is by IV. You put 20 units in a bag of normal saline and then just run it wide open. There is an option for 10 units to be given IM. Let's talk about misoprostol. So the reason I want to bring it up is because there may be some concerns out there, particularly for my fellow Texans, about using a drug that might inappropriately be labeled as something producing or leading to abortion. Obviously, there's a heightened awareness around here. When we talked about this before, you had a really good way of getting right to the point about this. Can you remind me what you said about misoprostol?
Sure, Jeff. Thank you. So it's actually in the title. It's postpartum. So by definition, postpartum means the baby's already delivered. So there's basically no way this could be tied to potential aborting a pregnancy because the baby's already delivered. This is strictly to control the hemorrhage that occurs afterwards.
I like it. So what you're aborting here is the hemorrhage. And I think
Right.
generally we may be a divided country, but I think everybody would agree aborting hemorrhage is a good thing. We don't like hemorrhage. I like it. Now, TXA, we use TXA for a lot of things. We use it for, my favorite use for it is for nosebleeds, but we use it in major bleeding. I think it's fascinating. The only thing that TXA is actually FDA approved for in the United States is this condition, postpartum hemorrhage. What is your take on the order that people should give these medications? And really more to the point, does it particularly matter?
So I think, oxytocin certainly has been most well studied. So I think if the ability to get oxytocin on board, the advantage too of oxytocin is it will continue to result in uterine contraction and therefore you maintain it as long as you need to. And then typically in the obstetric setting, oxytocin is run for several hours postpartum and then eventually discontinued once the uterus shows signs of contracting down and the bleeding has slowed to normal pretty much. We certainly recognize that TXA is available and widely used in other settings. In the obstetric settings, there is data certainly supporting TXA in the setting of postpartum hemorrhage, but it's not as robust as what's available for oxytocin, and for that matter, even misoprostol. So we list in our guidance TXA as sort of a second or subsequent line approach. I will say that similar to the discussion just had with Jenna about treating seizures and coming upon a patient, I think while you may not know whether the seizing patient is pregnant or postpartum, pretty likely you're going to know that hemorrhage in this setting is due to a postpartum hemorrhage.
The baby might give it away.
Right. TXA is the first thing available and easily accessible. That wouldn't be a bad thing. Ideally, TXA is given within 3 hours, so that's another consideration. But I think even if that's used and then oxytocin started afterwards, the key thing is guidelines are guidelines. They're great things to follow, but sometimes you got to adjust them a little bit. The main thing is to get control of the hemorrhage because, again, patients can lose a lot of blood before they're going to become tachycardic and hypotension. And by then, you're already playing catch up.
Well, I love this discussion. I think y'all have done a really amazing thing here by getting these guidelines together and getting them out to both of my communities, my emergency medicine community and my EMS community. So I thank you for that. Before we leave, are there any other things that we really need to hit on here? Anything else that y'all want our EMS community to know?
I think, Jeff, I'll just add a few quick additional points. One being, as Chris mentioned, in some cases, it's going to be really obvious that you're dealing with a postpartum hemorrhage, but potentially not. We can see significant postpartum bleeding, even up to several weeks after delivery. And certainly with hypertensive disorders of pregnancy, if this is occurring after delivery, patients may not necessarily relate their symptoms to a recent delivery. So I would underscore the importance of asking folks if they have been pregnant we're recommending asking within the last year, but I think for the conditions we're talking about today, certainly if they are currently pregnant beyond 20 weeks gestation or have delivered within the last 6 weeks, those are really crucial timeframes to inquire about. And again, to reference your point about there being some regional differences in access to reproductive health care, and asking that question in certain places in the country can be a little sticky these days. So there are ways, I think, to ask the question with the follow-up statement of like, I just need a yes or no answer. I'm not going to ask you any additional questions. I don't need any details, but having this knowledge will help me take better care of you, I think might be one way to ask it in a manner that does not have legal consequences for either the clinician or the patient. So that would be kind of just my first closing point, is to encourage EMS clinicians and ED clinicians, of course, to inquire about current or recent pregnancy. Secondly, to echo off of Chris's most recent discussion about postpartum hemorrhage, I would urge folks not to overly rely on the vital signs. In some ways, our guidelines are in stark contrast in that we're asking people to pay extreme attention to blood pressure in patients that might have a hypertensive disorders of pregnancy. I would say really don't pay that much attention to the vital signs if you have a patient who's having a postpartum hemorrhage, because as a result of the physiology that Chris outlined so nicely for us, patients can have very significant amounts of blood loss and have their vital signs not budge at all. So don't wait for your patient to become tachycardic or hypotensive. If they have ongoing significant bleeding after delivery, that is a cause for concern and needs to be treated. So a little bit of an interesting paradox in these guidelines with regards to the amount of attention we're paying to vital signs. And lastly, I just want to express my gratitude to our mutual EMS colleague, Dr. Taylor Ratcliffe, for his help in developing and promoting these guidelines, and also to his fine folks at Williamson County EMS who sat with us in community at the very start of this project and gave us their input on what they think would be most helpful, and helped us really identify some challenges that might be faced in the field with the applicability of treatment guidelines such as this. And I think really helped frame our ability to make a product that was useful to all. So just wanted to give thanks to those groups.
I love anytime there's a shout out to T-Rat or my friends at Wilco. I love hearing that. Thank you for that.
I would also like to give a shout out and many thanks to Nick Nadell from the American Paramedic Association, who has also been so instrumental in the development of these guidelines as well. So thank you, Nick, so much.
Thanks, Nick. Chris, any final thoughts?
And thank you again for the opportunity to do this. Just to echo Jenna's point, I mean, I can't overemphasize awareness is key. And if you don't ask about pregnancy or postpartum status, you're never going to recognize. And that even though there are risks potentially of maybe overtreating, the risk of undertreating or no treatment are significantly worse. So it's really the awareness to ask, and don't wait. Don't wait to treat the hypertension. Don't wait to treat the hemorrhage. It's so critically important. And again, thank you also to Taylor and the team. Thank you to the entire EMS EMT community for taking such interest in this. It's such an important consideration, and there's so much more we need to do. So again, really appreciate the opportunity to be on and just keep spreading the word.
Yeah.
To thank Arlene Remick and Nina Heithaus at ACOG for keeping us sane for the past 5+ years that we've been working on this. And also to Lisa Ollier at the CDC, who has been instrumental in being part of this project since the very beginning.
I love it. One of the things that I find the more projects like this I get involved within MSP is these are not solo efforts. It is a huge amount of work. Quite honestly, it's a big pain in the butt to try to get multiple organizations working together, but that pain is very much worth it. You end up with a much better product when you work together. So yeah, that's huge amount of work to get everybody together. All right, y'all. Thank you very much. I really appreciate this fascinating conversation. And hopefully we can use these guidelines to help shine a little brightness on the darkness of clinical practice. Thanks a lot, y'all, and have a great day.
You've been listening to the EMS Lighthouse Project podcast, a proud member of the FlightBridge Ed podcast family and a Fire Dog production. Visit flightbridgeed.com for more information.